One more minute to go, sir.
Okay, I'm ready.
Dr. Kiran will be introducing. After that, we'll start with them.
Sure.
So we are good to start, sir. Yes, sir, we are good to start.
Yes. So good evening, all. Myself, Dr. Kiran Varma, working as head of the department emergency Yashoda Hospital, Malakpet. So I welcome you all on behalf of Yashoda Group of Hospitals for the series of webinars conducted by emergency department on every Tuesdays. So today topic is big grade management of aortic disorders. So this is one of the commonest medical emergency or maybe sometimes surgical emergency which we encounter on day-to-day practice on emergency department. To enlighten on this topic, we have eminent teacher and professor Dr. Venkat Kotamraju, so who is consultant emergency department, London Debris Hospital, Royal Derby Hospital, UK. I welcome you, Dr. Venkat, sir. Please take over the mic.
Thank you very much, Dr. Kiran, and huge thanks to Dr. Srinath and Dr. Naveen, Dr. Kiran, and the whole Yashoda team for this fantastic opportunity. And thank you for the kind introduction. So the reason I wanted to talk on this topic, big red management of aortic disasters, is because I'm part of the aortic dissection working group in the UK. And also I do a lot of work as a medical examiner at Royal Derby Hospital. Let me start with a couple of stories, and that will reflect why really this topic is hugely important for us as emergency physicians. And these are true stories, true case histories, which presented to the emergency department in the United Kingdom. So first one is a 39-year-old gentleman who went to one of his local emergency departments complaining of chest pain, which radiated to the left side of his chest, his left shoulder, and also radiated down his left upper arm. And he complained of some pain in his biceps, and the pain was exacerbated by movement. So when he was seen in the emergency department, he was given some analgesics, and they did some blood workup, including troponins and D-dimer, both of which were normal. ECG was normal. His only background was he had hypertension and he was a smoker. So a diagnosis of musculoskeletal injury was made in his first initial visit, and he was discharged home with analgesia. He represented 5 days later to the emergency department, and the history was that he complained of severe chest pain, upper abdominal pain, which radiated to the back, vomited about 3 times. He was given IV morphine, IV omeprazole, and some analgesia, and a diagnosis of gastritis, stroke, pericarditis was made. Because he had some upper abdominal pain, they did an amylase, which was normal. So the team in the ED deemed that is not for surgeons, so they referred him appropriately to the medical team. When the medical registrar on the ward saw the patient, he thought that the differential doesn't look too bad of gastritis or pericarditis. He was seen by the medical team, and the medical team noted that this guy had bilateral blood pressure difference of about 27 millimeters of mercury between both arms in the systolic blood pressure. However, he was discharged home The next day, this gentleman, 39-year-old chap, was found in cardiac arrest and he could not be resuscitated. The case of another 49-year-old gentleman who presented again to his emergency department. He complained of non-radiating chest pain. And when he had pain, he complained that his vision was cloudy, he was a bit short of breath. So he had a normal ECG, so he had a normal troponin. However, his ECG showed T-wave inversion in the lateral leads. He was given analgesia, he was given GTN, he was given some aspirin. His blood workup, as I said, troponins were normal, but his D-dimer was found to be about 1600. The normal limit is about 500. So he was diagnosed as a query pulmonary embolism, given a low molecular weight heparin, and he was admitted under the medical team. His observations were stable and he was not scoring on any of his vital parameters. So the medical registrar who saw the patient thought that it was appropriate to bring this gentleman back the next day to do a CTPA. 10 minutes after this gentleman was discharged, he collapsed, had cardiac arrest, and he could not be resuscitated. Subsequently, because they were very young people, 39 and 49, both of whom died, there had to be a post-mortem which was conducted, and both of them were found to have aortic dissection as their post-mortem diagnosis. Can I go to the next slide, please? I think. Okay. So, as a result, the Royal College of Emergency Medicine came out with a safety alert about missed aortic dissections. And they talk about patients who have sudden onset of chest pain, back pain, abdominal pain, which is really maximum at onset. And particularly if you think that either of the pains are radiating to the back, particularly from the chest or the upper abdomen. Patients may feel very unwell. They may present with an episode of collapse or syncope. The pain may be intermittent. And if you can see two of the cases, in the first case, the patient had a normal D-dimer, a normal troponin, a normal ECG. In the second case, the patient had normal troponins, but he had some ECG changes and he had a raised D-dimer. We'll come on to the blood tests and radiological investigations in a moment. But none of these are really diagnostic. The only way to make the diagnosis is to do a CT scan. But the most important thing not to miss these cases is to have a high index of suspicion. Next slide, please. So the aortic dissection awareness in the UK, the Society for Cardiothoracic Surgery, and the Royal College of Emergency Medicine, all these three bodies came together and they devised a poster to say that if there is unexplained severe pain, particularly chest radiating to the back, abdomen, or back pain per se, think about aorta. And do a CT scan for a definitive diagnosis. And this poster, and along with a little small video, was presented to all the 230 emergency departments in the UK as well as Ireland, and it was distributed to nearly 6,000 emergency departments in the United States of America. So the key things to remember is, if you think about unexplained severe pain, think about aorta and do not delay in getting a CT scan, which is the only modality which will give you a definitive diagnosis. Next one, please. So really, to talk about aortic disasters, I'm going to concentrate on thoracic aortic dissections. A little bit about some of the background and definitions, classification, and then we'll talk about some management pearls and pitfalls. As you have seen, it's a life-threatening emergency, but it's a relatively rare condition. We see about 2,500 cases in the UK every year. Incidence is about 3 per 100,000 cases. 50% of these patients die before they reach a specialist center. And nearly 30% will die before they reach any hospital. And 1 in 6 are usually missed at the initial ED presentation. It's a relatively uncommon cause of chest pain, because if you think of acute coronary syndrome, that's about 200 times more common than thoracic aortic dissection. However, if you miss it, it's catastrophic, and in-hospital mortality is really close to 30%. So that's why having a high index of suspicion, particularly if somebody presents with chest pain, back pain, or abdominal pain, could be a young patient. We have seen 2 of our cases, which were relatively young patients, 39 and 49 respectively. And if the pain is usually migrating along the vector of the aorta, or pain above and below the diaphragm, or if they present with syncope or stroke-like symptoms, or focal neurological deficits, then you have to have a high index of suspicion. So migratory pain, pain which is severe and unexplained, pain which is sudden in onset, and pain if it's presenting with focal neurological deficits. When I say pain, I mean chest or abdomen or back. So next one, please. So if you look at the classification of acute aortic syndromes, we have 3 overlapping things. One is aortic dissection per se, which is really, there is a tear in the inner wall of the aorta, which is the intima, causing blood to leak between the layers. It is a sudden event, presence as a medical emergency. And after the acute event, if the patient happens to survive, they are at a risk of significant future complications, which will require intervention. So these patients usually, if they survive, they will require lifelong surveillance. On the other hand, an intramural hematoma is a condition where there is bleeding into the aorta without a tear in the inner wall. But it's like a time bomb sitting there. This intramural hematoma can rupture anytime. So essentially, you have to treat it on similar lines like that of a dissection. And third thing is a penetrating aortic ulcer, which is usually seen in elderly people who have atherosclerotic plaques, similar to atherosclerotic plaques in any major blood vessel. And this ulcer, you know, it's an ulcerated lesion which penetrates the layers. And of course, it can turn anytime, develop into an intramural hematoma or have a full-blown aortic dissection. Can we move on to the next slide, please? So there's the true lumen, and as you can see, you have the false lumen there. So the blood is dissecting between the layers. But the important thing to remember is when the blood dissects the intima, there's an intimal flap which is raised. So you have a true lumen and a false lumen. And pain is maximum at onset. When the intimal flap falls back, the patient may not experience any pain. So you could have intermittent pain, you could have migratory pain, and by the time you see the patient, he could be pain-free. So it's very important not to be fooled that if the to go by the norm that if the patient is pain-free, then it can't be a dissection. Please bear in mind that if the flap falls back, patient becomes pain-free. And for every hour that passes from onset of symptoms, there's an increase of 1 to 2% in mortality. So early, timely diagnosis is the key. Next slide, please. So if you look at the classification, we used to previously talk about the DeBakey classification, the Stanford classification, and they were confusing. But from a clinical perspective and from a management point of view, we talk about dissections in terms of a type A, type B dissection, or a non-A, non-B. Treatment and management of each type is different. Type A dissection starts in the ascending aorta. The risk of rupture is very high. It usually requires surgery to repair the aorta by a specialized cardiothoracic aortic surgeon. If you don't operate, mortality is 50% within the first 48 hours. Perioperative mortality reduces to about 20%. And 1 month mortality reduces somewhere from 90 to 30% if you take care of these people in a timely fashion. Type B dissections, they start in the descending aorta. The risk of rupture of type B is less than that of type A. These don't usually require immediate surgery, and they are mainly managed medically with blood pressure control in a high dependency setting with close observation for potential complications. And 20% of type B people, they might end up having complications which might need surgical intervention. And these complications may be ongoing pain despite treatment, refractory hypertension. So important to remember, patients, when they present, they may present as having high blood pressure, or they may have normal blood pressure, or they may have low blood pressure. Usually type A people present with low blood pressure, but they may be normotensive, and type B sometimes usually present with hypertension, but not in all cases, up to 50%. But if you have ongoing pain, if there is refractory hypertension, if there is extension of the dissection, if they end up with being ruptured, or if you have malperfusion of end organs like the gut or the kidney or the spinal cord or the lower limbs, then these people, type B, will require surgical intervention. And 40% of these people who have intervention, they will need treatment and surveillance lifelong, because you have to monitor for complications post-treatment, such as aortic dilatation and aneurysm formation. And depending on local arrangements, type B can be managed by cardiothoracic surgeons or vascular surgeons or the cardiologists. It varies from center to center. But essentially, type A, surgical; type B, medical management initially, unless, of course, you have complications. Then you have non-A, non-B. And 10% of people, they neither fall in type A or type B. Probably they have dissections which are limited to the arch of aorta. However, these again will need specialized care with a multidisciplinary team, which involves vascular surgeons, cardiothoracic surgeons, and interventional radiologists. Next slide, please. So as you can see, this is the dissection flap in the ascending aorta. So it's type A. And if you see the next picture, you will find Could we go to the next slide, please? Yeah, so you have the flap in the descending aorta. So type A and type B examples. Next slide, please. So what we have done in our hospital is we have devised a little scorecard so as to not miss these people. And if these people present to the emergency department and you suspect, if you don't suspect, if you don't think about it, if you don't try and investigate cases depending on the risk factors, then it's likely that you're going to miss. So we have devised a little clinical probability scoring to see what type of investigations they require. So the first box is what we call as high-risk conditions. So like Marfan syndrome or other connective tissue diseases like the Ehlers-Danlos syndrome. And usually people with Marfan's, they develop dilatation of the proximal aorta, which can then subsequently rupture and then give rise to dissection. Or if they have a family history of aortic disease, or if they are known to have aortic valve disease, if they are known to have a thoracic aortic aneurysm, or if they have had previous aortic manipulation, including cardiac surgery. If you have any of these high-risk conditions, then each of these gets a score point of 1. Next slide, please. And then we talk about high-risk pain features. So any pain, chest pain, back pain, or abdominal pain, which is sudden or abrupt in onset, which is severe, and which is described as sharp, knife-like, ripping or tearing, is very sensitive. So you have to ask these 3 questions. So think about aortic dissection as the subarachnoid hemorrhage of the brain. The sudden catastrophic, severe in onset, and it's ripping and tearing. It's really maximal at onset. So the time from the pain to maximal intensity is probably seconds to minutes. So if you have any of these high-risk pain features, again, you give them a score each. Next one, please. And then obviously, you look for high-risk features on clinical examination, like evidence of perfusion deficit. 20% of people may have, from the normal population, will have some difference in blood pressure in both the arms of greater than 20. What is more important is if they have a wide pulse pressure, then obviously you will have to think of that as more significant. Or if they have aortic diastolic murmur, either the murmur is associated with pain or it's a new aortic diastolic murmur which hasn't been recorded before. Or if they're present in hypotension or shock. As I alluded to earlier, not all patients present with hypotension, particularly type A, may present with hypotension because when they present initially with chest pain, they might present with risk factors like the type A dissection rupturing into the pericardial sac, so they might end up with pericardial effusion, or they may even end up with cardiac tamponade, or they may end up with heart failure. So these patients may be hypotensive, or they may present in cardiogenic shock, depending on how the rupture takes place in the place. But type B may not present with hypotension. They may be hypertensive or even normotensive to start with. So again, you score one of these. So 3 things really. Next slide, please. Then your clinical probability scoring is you take the high-risk conditions, you talk about the high-risk pain features, and then the high-risk exam features based on your clinical assessment. And then we have devised a tool. Next slide, please. So if you think you suspect dissection of the thoracic aorta on history, then you look at their hemodynamic state. If they're unstable, obviously, you want to call the senior-most clinician in the ED as well as the cardiologist on call. And then you take them for immediate CT aorta, provided they are stable. However, most places now, we have the scan just next to the emergency department, and we can take them with close monitoring, either by the ED team or the intensive care team. And if you think they are very, very unstable, you can do a bedside transthoracic echo. We'll talk about the transthoracic echo and its limitations in a minute. If they are stable and you think they have a low probability score, then we do a D-dimer and a chest X-ray. And depending on how strongly you suspect, you can probably order for a transthoracic echo. Usually it's easier in the daytime hours because we have specialist echocardiographers who can come and do it from clinical measurements team, but out of hours, it can be challenging to get a TTE. If they're all normal, particularly the D-dimer and chest X-ray, we tend to think about alternative diagnosis. However, it's important to bear in mind only in people with low probability scoring. If you think they have high probability, or if they have sudden severe tearing chest pain, where the likelihood ratio is very, very high, then you don't go on to waste time to do D-dimer, chest X-ray, TTE, etc., etc. You go in for a whole CT aortogram. Next slide, please. So then, keeping all this in mind, we talk about really three things as to how we can best manage these people. And I've just divided them up into pain pulse, diagnostic pulse, and treatment pulse. Next slide, please. If you talk about the pain pulse, firstly, I talked about and alluded to that if you have sudden, severe, abrupt onset, severe pain, pain which is radiating to the back, chest, or from the chest to the back, or from the back to the chest, or the abdomen, or migratory pain above and below the diaphragm, then it is quite significant. That's number one. The second thing is also you have to think about pain being, if you get somebody who's got severe colicky pain and you're giving a lot of opioid analgesics, then always think whether this could be aortic dissection. The third thing about the pain is pain could be intermittent, and when you see the patient, they may not have any pain. That is because as the dissection of the intima stops, you will not have any pain, and when the dissection starts again, the pain will reappear. So don't be fooled by intermittent pain. And lastly, we talk about the concept of chest pain plus one. The tear in the intima, because it's a really big blood vessel, the aorta, it can devascularize any organ from the head, including the brain, including the heart and the kidneys. And a lot of these may present or sometimes may present with symptoms of stroke, or patients may come in with syncope or collapse. But the chest pain plus one phenomenon is particularly if you have somebody who's presented with chest pain and they have paralysis, or chest pain with limb ischemia, or chest pain with hoarseness of voice, which affects the recurrent laryngeal nerve. So chest pain plus one, if you think, if they particularly present with symptoms other than these, then you need to be very careful. Of course, we're not going to ask every patient who presents with stroke whether they had a chest pain, but there won't be any harm to ask them whether they had chest pain in the preceding days before the presentation of a stroke. And if they did, and there was intimal dissection, which initially formed an intramural thrombus, and subsequently the dissection flap was there, and there was no further dissection, so they didn't have any pain, they didn't think about it. And 2-3 days down the line, they present with a CVA or focal neurological deficits, then obviously it's a good question to ask, particularly in young people who present with stroke symptoms. and don't have many risk factors other than hypertension. It may not be an unrealistic question to ask. So these are about the chest pain pearls. So really concept of chest pain +1, concept of severe abrupt onset of pain and migratory pain. Then if you look at diagnostic pearls, troponins and D-dimer. 25% of the patients may have positive troponins, particularly in type A. But the two cases that I told you at the beginning of the lecture, both of them had normal troponins. So it's not really a helpful test to rule out dissection. It may be helpful in situations where you are thinking about acute coronary syndrome, but we can't be fooled by patients who have a normal troponin and say they don't have a dissection. They may not have an acute coronary syndrome, but they may well have a dissection. D-dimer, again, very sensitive for picking up most dissections. Sensitivity is somewhere between 94 to 97%, but specificity is only somewhere between 34 to 100%. So several authors, they suggested D-dimer is a screening tool to rule out thoracic aortic dissection. But the problem with D-dimers is the false negative rates are very high as up to 18%. However, if you have higher D-dimer levels, like in the second case, is D-dimer about 1600, it might correlate with more segments of the aorta involved. It might correlate with false lumen type of dissections, and it might correlate with higher mortality rates. D-dimer may be low in patients with intramural hematoma because the forming clot, it's still forming, it's not exposed to the circulation. So they won't have, because it's fibrin degradation product, and you may not have raised levels in the circulation. However, if you want to really rule out thoracic aortic dissection with a negative D-dimer, the pre-test probability has to be very, very low. May be useful to rule out dissection in low-risk patients, but really there are no current validated scores. So you can't use it to actually 100% rule out a dissection. It may help you in certain circumstances, but don't depend on it entirely to rule out an aortic dissection. ECG, again, in 30% of the cases may be normal. Like in the first case, which I presented, ECG was normal. The second case, troponin was normal, but ECG had T-wave inversion in the lateral leads. But in 30% of cases of thoracic aortic dissection, ECG is normal. Chest X-ray, 15% of patients have a normal chest X-ray. A normal chest X-ray does not exclude a diagnosis of thoracic aortic dissection. Main use of chest X-ray really in patients who present with chest pain is to exclude alternative causes, like pneumonia, for example. And as you know, the chest X-ray there are lots of signs which may suggest, including a widened mediastinum. Next slide, please. Or you can have an abnormal or blunted aortic knob. So the picture on one end of the screen shows the normal aortic knob, and the other end shows the blunted aortic knob. Or you can have a calcific ring. You can have pleural calcific ring. So if it is, you measure, and if it is 0.5, it is suggestive. And if it is about 1 millimeter, then you know it is highly suggestive. But it's not 100% test. And you measure it from the outer wall of the aorta. Or you can have pleural effusion, particularly on the left side. Or you can have pleural cap, which means there's fluid in the apex of the hemithorax. You could have deviation of the hemithorax, deviation of the trachea and the left main bronchus. So there are lots of signs, about 12 signs for thoracic aortic dissection on the chest X-ray, but none of these are really diagnostic. They may help you to decide, okay, there is a problem here, and do I need to think about thoracic aortic dissection? But don't depend on the chest X-ray to make a diagnosis. If you think about it based on the chest X-ray, then go in and order a CT, given you find other clinical findings and your examination. Next one, please. So in your own mind, this 68-year-old gentleman presented to our emergency department about 4 or 5 weeks ago. And he was seen by one of the doctors. And he had presented to another hospital with a spontaneous pneumothorax sometime in November. He had a chest drain put in. And essentially, he came in with a history of feeling unwell, intermittent chest pain, and pre-syncopal episodes. And his wife gave the history saying that, I'm finding it difficult to keep this chap awake. He keeps falling off asleep intermittently, and he seems at times to sort of, go off balance and collapse. He had this ECG done in the emergency department. And for the discerning eye, you can see he's got an ST elevation in the inferior leads and some reciprocal changes with some ST depression in the anterolateral, sort of V2 to V6 leads particularly, maybe even in a little bit in V1. So you would think for the discerning eye, for all practical purposes, somebody who presents with a chest pain with inferior ST elevation and reciprocal changes, because the inferior goes usually with posterior and lateral changes. With these reciprocal changes, you would refer him to the cath lab, which they did. And he was taken to the cath lab as a STEMI. And in the cath lab, when they were performing the cardiac procedure, the PCI, as you call it, they started doing some images, and then they decided this guy these changes are not really related to his coronary ischemia. And then they ordered a CT scan. Next one, please. And that's what you find. So he's got a dissection. And then this gentleman was referred to the cardiothoracic surgeons. Unfortunately, he was referred and, he was straight away put into the ambulance, but 10 minutes into his journey. So we are based at Derby, and Nottingham is our closest center, and it's about 14 miles. And 10 minutes into his journey, he had a cardiac arrest and he could not be resuscitated. So sadly, this gentleman died. A few years ago, going back to 2017, the Healthcare Safety Investigation Branch in the UK, they brought out a nice paper because a 45-year-old gentleman who came into the emergency department, thankfully on this occasion, the treating clinicians decided that he had, or he was suspected to have a thoracic aortic dissection, rightly based on their clinical examination and investigations. They decided to order a CT aortogram. And it took about 4 hours before this gentleman could get a CT aortogram. And then once it was diagnosed that he had a type A dissection, he was in a small district general hospital, which didn't have facilities for aortic surgeons. So he was referred to the next specialist center and took another 2 to 3 hours before he could be transferred. He's a critically ill patient. So right from the time presenting to the emergency department to being seen, to having a scan, and then being referred was nearly about 8 to 10 hours. Unfortunately, again, this gentleman couldn't make it to the specialist center. And as alluded to in the beginning, 30% usually die even before they reach any hospital. And sadly, he died as well. So that's why they have created an aortic dissection working group, which focuses on timely and prompt transfer of these critically ill patients between specialties from one hospital to the specialist center. Next slide, please. So the take home really is if you think about somebody who has an aortic dissection, then CT aortogram is the gold standard. It is the definitive diagnosis. Not an ECG, not a chest X-ray, not D-dimers, not troponins, not even a transthoracic echo. Transthoracic echo will miss 30% of dissection. So 1 in 3 people, if you do a transthoracic echo, it's very operator dependent. It will miss 1 in 3 dissections. Transesophageal echo is more sensitive than transthoracic. But of course, as you all know, these are things which are very difficult to get in a timely manner in emergency departments, even in specialist centers like in the UK or the US, for example. The other important thing for transthoracic echo, especially if you have an unstable patient, you might be able to identify tamponade. That may be helpful because you could do it at the bedside, especially in type A dissections, because they can present with either tamponade or with pericardial effusion. So in CT scans, initially you do a non-contrast CT as part of your scanning protocol. And that helps in, it's got value in assessment of intramural hematoma. And then you do a post-contrast CT. And this post-contrast CT can really look for a false lumen. It can look for the location, exact location of the dissection flap. You can look for extension into the great vessels. You can look for signs of aortic rupture. And it can also give you information about end organ damage. And if it's involving any of the branch vessels, I said it could devascularize any of the organs, like the lower limbs giving you ischemia there, or the gut giving you mesenteric ischemia, or goes up to the brain, ends up with stroke symptoms and focal neurological deficits. And then you have to do something called as the arterial phase acquisition. And they do it with ECG synchronization. And you call this as a gated scan, because really you want to have motion-free images of the aortic root, particularly if you're suspecting people with connective tissue disorders. Because Marfan's and Ehlers-Danlos, these people have dilatation of the aortic root because of their connective tissue problems. And that's where the problem lies. So if you don't have motion-free images and there are a lot of artifacts, then you won't be able to diagnose it very well. So CT scan is the gold standard. Next slide, please. So finally, the management pearls really, they rotate or they revolve around these 3 things. One is pain management, blood pressure control, and heart rate. Patients who usually present with pain, and if they continue to have pain, then it's not a good feature because they will have a lot of sympathetic response. And this sympathetic response to pain as a result of pain may in turn contribute to their high blood pressure and the high heart rate. So we need to first control their pain to counter the sympathetic contribution to the hypertension and the tachycardia. So you could use something like fentanyl boluses to control the pain. So the first thing is to control the pain. And the second thing is to control the blood pressure and the heart rate. There's no magic number, but most of the studies say that if you control the heart rate to about less than 60 and the blood pressure to about less than 110 systolic, essentially they call this as the anti-impulse therapy. What does that mean? It just means that reducing the blood pressure and the heart rate decreases the shearing forces on the intima. As a result, it will prevent the extension of the dissection flap. Because as a result of the shearing forces on the intima, there is a tear in the intima, which creates a dissection in the walls of the aorta, and then creating a false lumen. And then, you know, when the blood keeps shearing, the pain keeps increasing, the flap keeps increasing, and the risk of rupture increases. So you want to do that treatment. So firstly, heart rate control to a goal of 60. You could use either esmolol or labetalol. They have a negative inotropy and a chronotropy effect. Esmolol is better for the simple reason that it's rapid onset and it's easy to titrate, but we use labetalol as well in our department. And blood pressure control, essentially, you can use either nitroprusside or nicardipine. Nicardipine is a pure arterial vasodilator, so it will help in afterload reduction. But the important thing to bear in mind is you don't want to give a vasodilator without concomitant reduction in inotropy. If you give a vasodilator without a concomitant reduction in inotropy, like the esmolol or labetalol, then you will end up in trouble because that will result in progression of the dissection. And it's not a favorable outcome for the patient. So 3 management pearls in order: pain control, then control the heart rate to about less than 60, and then blood pressure management to aim to a systolic of less than 110. Next slide, please. So really, to put it all together, why the Royal College of Emergency Medicine talked about this safety alert and missed aortic dissection. So in the 2 cases that I gave examples at the beginning of the talk were 2 cases where people didn't think about dissection, and they talked about alternative diagnosis like musculoskeletal injury. In the first presentation of the first gentleman of 39 years old, he represented with a history which suggested that he had chest pain which radiated to the back, severe in onset, when he was sat on the sofa. And again, it was misdiagnosed and missed. Referred to the medical team, who again missed it, and the patient sadly died. That was the first case, 39-year-old. The second case, 49-year-old gentleman, although he had non-radiating chest pain with ECG changes, with a raised D-dimer, and it was again misdiagnosed as gastritis pericarditis, and the raised D-dimer was thought to be contributing to the possible of pulmonary embolism. He was given enoxaparin, which is again not indicated in this situation for dissection. And then he ended up 10 minutes later dying. These 2 cases were in different hospitals in the country, not in our emergency department. Let me give you examples of 2 cases which I was involved in. The first case was, I went on a Saturday morning. It was very busy. We had about 7 hours wait to be seen. And one of my juniors picked up one of the patients. She was a 72-year-old lady. And she was going through the notes, and she came to me and said, this lady has got a troponin of 21. The upper limit is 13. And she said, oh, I think it's ACS. So I'm going to admit her. So I'd only just arrived. So I said, okay, have you seen the patient? She said, no. So I said, could you go and kindly see the patient, please? By which time I'll just have a look at the notes. So then I started looking at the notes. And the triage history said the patient arrived at 2:30 in the early hours of the morning. And at 2, and it's recorded chest pain radiating to the back. The nurse was concerned, and she called one of the registrars to come and have a look. And she's clearly documented in the notes saying, chest pain radiated to the back. I have asked one of the registrars, we call them the senior decision makers. Obviously, there are no consultants between 2 and 6 in our hospital. So it was 2:30, sometime around 3 o'clock. For some reason, there's no documentation to say whether the registrar actually went to see the patient on initial assessment. And 7 hours down the line, this junior doctor went to see the patient. She was still complaining of pain 5 out of 10. And then she decided to give her some morphine. The pain settled down. Subsequently, 10 minutes later, the patient gave a big howl because she probably had a massive ripping pain in her back, went completely pale white, and collapsed in the bay. And we had to wheel her into the resus. We could not resuscitate her, and a bedside echo showed massive pleural effusion on the left side, obviously, and post-mortem found she had a dissection, and she died. Second case was a fit and healthy gentleman, 65-year-old, who came into the emergency department during COVID time. And he said, I was cycling and I developed sudden pain in my chest and some back pain. When he came to the emergency department, the pain had settled down and he was looking well. Seen by one of the advanced care practitioners who came and discussed with me. Based on the history, I said, get a CT aortogram because this looks like aortic dissection to me. Fit and healthy person complaining of sudden onset of pain. It looks like aortic dissection until proven otherwise. The clinician spoke to the radiologist who refused to do a CT aorta, said, do a troponin. His ECG was normal. Troponin surprisingly was normal. Then we had to speak to the radiologist to get a CT scan vetted. About 2 hours later, I was called to see this patient because again, he had started complaining of severe pain. When I went and saw him, he was almost turning pale, this guy. So I told the clinician to arrange to transfer him to resus straight away. He was still awaiting a CT aortogram, which had then been agreed by the radiologist. However, within 2 or 3 seconds, he collapsed, had a cardiac arrest, and had an unsuccessful resuscitation. The postmortem found he had an aortic dissection. So in the first 2 cases, they didn't think about dissection, and subsequently they had dissection. In the next 2 cases, we had an opportunity because we had correctly had the history and we correctly diagnosed dissection. Possibly the outcome would have been the same because these are all catastrophic events and aortic disasters. That's why they're called aortic disasters. But either way, one way or the other, they were either missed completely or they were missed for a length of time. So that's the reason, really, if you think about somebody who's got sudden chest pain radiating to the back or to the abdomen, which is maximal of onset, they may feel very unwell. They may present with syncope or collapse. Pain can be intermittent. Blood tests can be normal. ECG, chest X-ray may be normal. But you have a clinical suspicion. The only way to make a diagnosis is to do a CT aortogram. Next slide, please. Finally, think of aorta. Aortic dissection is an emergency that is often fatal when it is missed. And I hope I've convinced you with the 4 cases that I've talked about. It's not an easy diagnosis to pick up. But the most important message that I would like to give all of you is to think about it. And if it fits in with your clinical examination, suspicion, and clinical probability scoring, please try and get a CT scan at the earliest possible opportunity to get a definitive diagnosis one way or the other, and a prompt referral to the cardiothoracic surgeons or the aortic specialists or the medical teams like the cardiologists, depending on the type of dissection, to help manage these patients better. Last slide, please. So finally, we've talked about some background and definitions. We've talked about the classification, and I've given you some management pearls and pitfalls. And I hope you will remember that Big Red is an aortic disaster if you fail to manage. Thank you very much. I'm happy to take any questions.
Yeah, thank you, Dr. Venkat, sir. That was informative and elaborative talk. So before concluding our session, we'll go for some questions, sir, which they put up in our question box.
Sure. Yeah.
So first one, so what are the ECG changes in aortic dissection?
As I said, 30% of the cases may be, the ECG may be normal. There are no specific changes to say that if there are these ECG changes, then it points to dissection. So the takeaway points for ECG are in 30% ECG may be normal. You can have STEMI type of pattern like the ECG and the example which I showed live, and usually it presents with the inferior STEMI pattern. Or you could have non-specific changes like T-wave inversions. But don't rely on the ECG to make a diagnosis of thoracic aortic dissection. So that is takeaway for ECGs.
Then another question, sir. Role of BNP as marker for aortic dissection.
Well, even the clinical probability and the aortic dissection guideline that is given in or we follow in our hospital based on the Royal College of Emergency Medicine and the Royal College of Radiologists guidelines doesn't include BNP. Some of the type A dissections may present with heart failure, but really there is no role of BNP as far as I'm aware, or there are no real studies to suggest that we do BNP in these cases. And they're not going to be helpful in any way to think about dissection one way or the other, either whether they're raised or normal or low, for example.
Yeah, another question, sir. Please enlighten about aortic dissection detection risk score.
So this is the one, the one which I spoke about is the one which is the aortic dissection risk score. So if you go back to my slides, I talked about three things, isn't it? In the clinical probability scoring. So because there haven't been many studies, so people talk about the aortic dissection risk score. So we have collaborated all this evidence and we have brought about these three things really. That is the high risk features, then high risk pain features, and the high risk clinical examination findings. And as I said, if you have a low probability aortic dissection score, think about doing chest X-ray D-dimer, but only in people with low scores. If they have high score, you go for a CT aorta. Or if you're suspecting that they have severe pain, we still go for CT aorta. Or if you think that, you know, there's a high degree of suspicion, even with a low score, go for CT aortogram. The score is only helpful for very low probability cases.
Yeah, thank you, sir. I think we are done with the questions. So thank you all the viewers for attending on this webinar. So we hope that we'll continue to watch our series of webinars conducted by Emergency Department, conducted by Yashoda Group of Hospitals. I thank Dr. Venkat Kotamraju, sir, then Dr. Srinath, sir, and Yashoda Group of Management. I thank you and all.
Yeah, thank you very much. And again, my sincere
thank you,
thanks
Dr. Venkat. Thank you, Dr. Venkat. It was really enlightening talk on this very essential topic for emergency medicine. And you have rightly hit the points which has to be noted in the emergency department and to be taken care of when the patient comes. And high degree of suspicion only will save the patient. Without a high degree of suspicion, it will never save a patient with aortic dissection. Thank you very much. On behalf of Society for Emergency Medicine India, on behalf of Yashoda Group of Hospitals, I would like to take this opportunity to thank you for giving your highlights and how to manage the patient. Over to you, Kiran.
Thank you very much.
Thank you, Dr. Srinath, sir.
Thank you.